Each year, millions of adults in the U.S. are diagnosed with vascular disease. And it's no wonder. With over 60,000 miles of intricate arteries and veins throughout the human body, there are bound to be complications due to blockages, weakening of the blood vessel wall, and other issues impacting the circulatory system. With an aging population and the growing incidence of risk factors such as diabetes, high blood pressure, obesity, smoking, and the disproportionate incidence of vascular disease in our minority populations, the management of vascular health is becoming a key focus among today's healthcare leaders and providers. As with any medical disease or condition, it takes an entire team of dedicated professionals to find new ways to efficiently diagnose and treat patients, as well as to improve their long-term care. In vascular health, the leader of the team is today's vascular surgeon. Only vascular surgeons dedicate their entire training and practice to address the full spectrum of vascular health, as well as provide comprehensive care that includes preventive, medical, surgical, and minimally invasive solutions. Through ongoing education and research, as well as pioneering new techniques, vascular surgeons are on the leading edge of clinical breakthroughs that are transforming vascular health. As part of their comprehensive approach, vascular surgeons partner with other healthcare professionals to provide quality care tailored to each patient. This patient-centered model is vital to help all physicians manage vascular health in at-risk populations and promote healthier lifestyles in the future. Vascular surgeons are involved in every part of the disease process, from making the diagnosis to the management of disease. Vascular surgeons are comprehensive leaders in vascular health. Today's vascular surgeons are creating a new chapter in the vascular health story with improved patient care, better outcomes, collaboration, and leadership. Surgery is only part of our story.
Hello, my name is Dr. Alan Lumsden. I'm the Medical Director at the Houston Methodist DeBakey Heart and Vascular Center. Thank you for joining us today. It's a real privilege for us to work with the SVS in talking about COVID-19 and the issues that are arising for vascular surgeons. So with that, I'm going to kick this off to my co-moderator. That's Dr. Kim Hodgson, who's the President of the Society of Vascular Surgery. Kim.
Thank you, Alan. I'm going to share my screen with you here now. All right, well, I'd like to welcome all of our viewers to our first in our planned series of SVS Town Halls on COVID-19. I'll be co-moderating today with Dr. Alan Lumsden. Picture is not coming up here. We'll get him. Dr. Alan Lumsden, Professor and Chairman of Cardiovascular Surgery at Houston Methodist Hospital. Houston Methodist is not only sharing Dr. Lumsden with us today, but also their video production facilities, which are making this transmission possible. We greatly appreciate their generous contribution to this effort, and particularly that of Alan's studio manager, Tyree Horn, without whom we would not have been able to get this off the ground so quickly. It's somewhat ironic that we're doing this here today under these circumstances. As many of you know, Alan is scheduled to deliver the Greenberg Lecture at BAM this year on the topic of virtual education, training, and proctoring, one of the many areas he has pioneered. Little did we know when I selected him for this honor that we would be piloting his vision before we even got to hear his lecture, but here we are. Our first town hall is focused on the practice implications of COVID-19 pandemic, and we are joined today by 4 panelists with distinct insight into navigating the COVID-19 waters. Benjamin Starnes is Professor and Chief of Vascular Surgery and Vice Chair of Surgery at the University of Washington in Seattle, ground zero for the COVID-19 outbreak in the United States. Ben is further along the pandemic curve than anyone in the United States and will provide us with his early insights into how to appropriately respond to this threat viewed through his unique military perspective. Our next panelist, Tom Forbes, is Professor and Chairman of Vascular Surgery at the University of Toronto. Tom serves as chair of the SVS Doc Committee and has worked with Bill Schutz to collect and compile all the case prioritization algorithms that SVS members have submitted to Connect. He brings his insight into case prioritization and the Canadian perspective to our panel. Also joining us is Dan McDevitt, President and CEO of Peachtree Vascular Specialists in Atlanta, and also an SVS Executive Board member representing the clinical practice community. Dan has a busy office-based lab and will be sharing with us his thoughts about the challenges of maintaining patient access to care in the face of COVID-19. And lastly, SVS President-elect Ron Dahlman, Professor and Chairman of Vascular Surgery and Associate Dean for Market Development at Stanford University School of Medicine. Ron is going to share with us information about personal protection in the COVID-19 era and university and institutional resources that can assist in navigating those waters. With those introductions behind us, but before we get going with our first SVS Town Hall, let me take a moment to mention two more upcoming SVS COVID-19 Town Halls. The second in our series, also co-moderated by Alan and I and hosted by Houston Methodist, is scheduled for this exact time next Friday, April 3rd. This town hall will focus on the education, training, and wellness implications of COVID-19, and as you can see, has SVS leaders well versed in these issues, including Ravi Sher, Dawn Coleman, Amy Reed, and Gib Upchurch. The third SVS Town Hall is under development and will be co-moderated by Judith Lynn and myself, and will focus on telemedicine platforms and their use in the COVID-19 era. Later in this broadcast, we'll be polling you about other topics you might like us to cover in future SVS Town Halls. The point is here that there's no reason for us to be learning about this alone. So I'm going to be giving this back to Houston Central here, and we're going to be going ahead and kicking this off. I wanted to just let you know that just about 72 hours ago, as we were working to pull this together, we became aware of what we believe is the first SVS member, at least known to us in the United States, to actually contract COVID-19. And it turns out he's a recent fellow graduate of Alan's named Ali Irshad. Alan and I had a call with him the other day, and I'm going to let Alan take it from here. Alan?
Thank you, Kim. Again, of the many concerns that we all have during this outbreak, one of them that features pretty highly is concern about contracting COVID-19. And so with that, we're going to run that recording. Ali is one of our ex-fellows and very graciously agreed to talk about his personal experience, how this probably arose, how he dealt with it, and how he's kind of re-emerging and heading back to practice. So if we can go ahead and run that video with Ali. And again, on behalf of everybody, Ali, thank you for being bold enough to allow this to be presented.
Yeah, I like to meet new SVS members, but you are in fact the first and only SVS member that we are aware of at this time who has contracted COVID-19 and actually had to deal with the disruption that this brings to your practice. So perhaps you could start by just telling us a little bit about your story.
Thank you for having me, guys. Yeah, so I am the first one at my hospital as well for contracting this, at least as far as the surgeons and the physicians go, the medical group. So briefly, what happened was last Sunday, I started having pretty bad headaches in the evening, retroorbital pain, which sort of worsened overnight. I woke up the next morning around 5 a.m. I had a first case that day. I didn't think much of it. It didn't occur to me that this would be due to COVID or due to coronavirus, because I really didn't have, at least at that time, I did not think I had any contacts that were sick, or I hadn't left the country or been to any of these states that had this particular issue. Went to work. First case, my first case was at the Boyne Joint Institute. It was an ALIF I did with my partner. And basically halfway through that case, I started feeling really, really bad. I started having worsening myalgia. The headaches got worse. I had a subjective fever. My eyes were burning. And, I was having a hard time even finishing that case. So for the skin, even closed skin, I actually scrubbed out. I let the resident and my partner take over. And I called my chief and told them, about the symptoms I was having. Immediately at the time, I figured I could take some meds and just kind of plow through it and continue with the day. It was my call week. But I figured that, if this is the real deal, if this was COVID, then that's probably not the right thing to do. So, that immediately I went home, put on a mask, walked to my car, went home, and it just continued getting worse. I took my temperature when I got home. It was about 102. And it was, I was coming down pretty hard. I was able to, by the next morning, I was able to secure a COVID test. It was through the drive-through. Hartford Healthcare had just started that, and I was probably one of the first people to go through the drive-through to get that done. Very well done. It was, minimize my contact to anybody. I was sort of just in my car. And we got that done maybe Tuesday morning. It was 9 o'clock in the morning. Went back home, and then I continued getting worse. My symptoms got worse. I had actually one of my partners went and bought a pulse ox for me from CVS, and dropped it off. So I started using that, and I'm relatively healthy. I run quite a bit. I do martial arts 3 times a week. So respiratory wise, I don't have any kind of issues, but by Tuesday night, I was having difficulty completing an entire sentence without becoming short of breath. And then the pulse ox was showing that it was high 80s, low 90s. So it was starting to get concerning. There wasn't much in terms of direction, quite frankly, from the hospital, because they weren't really sure what to do. I was just told to stay home. And if it got really bad, I was supposed to come in and come to the ER and possibly get admitted. But I wasn't at that point yet. So actually Wednesday, by Wednesday, I'd been studying a lot, reading a lot online, trying to figure out what different methods that people were using. I learned of a trial in France, and obviously none of these were sort of randomized controlled trials, but in China and France, they had done some reporting of using hydroxychloroquine. And I looked at the dosing, and at that point, I was sort of somewhat out of desperation. I actually decided to treat myself. So I prescribed it to myself, had it picked up, and I started taking it Wednesday. And by Thursday, around midday, I started feeling better. I don't know if it was because of the medication, or it was just the nature of the disease, but I started to improve. And then by Friday, I pretty much felt back to normal in terms of my breathing, and no myalgias, no fevers, no headaches, and started feeling much better. Throughout that time, I just kept myself quarantined, though.
So I understand that you are in self-isolation in your home. Is that correct?
Yes.
Nobody else, to your knowledge, in your home has been infected by this yet?
So my wife actually, we were worried about my wife being affected. We were able to eventually get her tested. And actually just today, she got her results back and she was negative. So
how long are these tests taking for you to get this information back?
So it's interesting. The positives are taking longer, is what we've learned. So I got mine done on Tuesday morning. I didn't get my results till Saturday. My partners, so every single one of my partners, because we were in close contact after I went home, each one of them was tested. They all got tested midweek and onward, and most of them got their results back in about 2 days. So what we realized that if you don't get your test back in a fairly short amount of time, the likelihood of you being positive goes higher, because I think they screen first. I'm not exactly sure what the details are, but they screen initially for the antibodies, and then they go back and they do the PCR. And I think that can take a lot longer. So for me, it took a total of 4 days. Another cardiac surgeon that's in my practice, who also tested positive, his also took 4 or 5 days. So we are realizing that essentially if it's taking more than 2 days for your results to come back, the likelihood of you being positive goes up quite a bit. Obviously that's anecdotal from our side, but that's what we've noted. And so far there's 3 of us, 2 cardiac surgeons and me, who tested positive. The 2 other guys, they actually did not take. Well, one of them was not able to take the medication because it just completely sold out by the time they kind of got wind of it. And then the other one did not take it up until yesterday. He was still having symptoms, and he's been still at home and still having symptoms. I would say my symptoms resolved fairly quickly. It still took about 5 days, but by the 5th day, they got much better.
So I understand you have a theory as to how you got this, or you figured out the mechanism, which is a cautionary tale for all of us, I think, in these times of social distancing.
So, we think we kind of pinpoint this all going back to, and I won't mention the device company, but a particular aortic device company. We were all at this training session the week before that. So, my symptoms started Sunday, Monday. The Monday before that is when we had in contact with several folks from this company. It was a 2-day event, and one of the people that was there, one of the representatives from this company, apparently had some symptoms at the time, and then was found to be COVID positive. 24 out of the 25 people that were part of his group also had symptoms, also went home. And then the three surgeons that all tested positive were at these training sessions and or the dinner. And what's remarkable is that we weren't sitting at the same table, the dinner table, as the person in question who was positive at the time. We were not all that close to that person, but we were in that same room. We were in the same surroundings, and it seems like it was the virulence of this was very remarkable. That 24 out of 25 people got symptoms. 5 of their reps actually ended up testing positive so far. I don't know about the others. And then 3 of us, just being in their vicinity, were able to also acquire this virus. And so it just kind of speaks to how virulent this can really be.
So what's going to be the process for you to return to work?
So it's interesting. I know from what I understand, the CDC as well. So the CDC's sort of official statement on this is that you have 3 days from symptom-free without any antipyretics, or 7 days from your initial symptoms, whichever one's longer, is when they say you can go back to work. And that's the same thing I've been told by the VP of our medical group, that once I am feeling better and it's been 3 days, I can actually come back to work. Now, I will say that in my group, and my partners who've been very supportive, they said, don't bother doing that. Come back, take the rest of the week off. And that's exactly what I did. One of the things that happened is, as soon as I was quarantined, was I had to cancel all my cases for that week. And then I called all my patients for the next week and, pretty much canceled everyone or reassigned them to one of my partners, especially post-ops that absolutely needed to be seen. Amongst our group, we kind of decided that we were going to start treating the next couple of weeks like weekend call. So every couple of days, one of us is taking call as the person that's in charge, and they're basically treating it like a weekend. We're only doing emergent cases, and they're not really seeing patients in clinic unless they absolutely need to be seen, or they're doing telemedicine for those patients. They're using Zoom, just like we're using right now, and it's been working well. Obviously, it still has its kinks, and we have to work those out. But we've really minimized our schedule to essentially a weekend schedule.
So Ali, let me ask you a question, because if I remember rightly, your wife's a nurse.
She is. She's a nurse practitioner for the structural heart program, and since I got once we found out about the device reps that were positive, she actually had to go home. She unfortunately was in quite close proximity, not just to me, but also the 2 surgeons that were also tested positive, because they're a cardiac surgeon. She works with structural heart. She's in the same meetings as them. So she was actually told to go home. And she was tested just a couple of days ago, and she tested negative.
So I know that you're not long up there, and you've not bought a house yet. You're living in a 2-roomed apartment. So tell us a little bit about what being quarantined means and how the family has handled this. I mean, you have a relatively young baby.
So I have a 5-year-old, and since I started feeling poorly, I mean, we were gonna minimize our exposure to our son anyways, especially me, because I was supposed to be on call that week, and we knew, it could get pretty ugly. So we were gonna minimize to begin with, but once I got symptoms, I, basically locked myself in our master bedroom. We have a 2-bedroom apartment. As you said, we're still sort of looking, and we're like, looking at homes and still trying to figure out where we're going to move to. So we've been renting thus far. So it's not a lot of space. And as soon as this happened, I basically barricaded myself in this room. So I just have a bathroom and a master bedroom. And I did not leave this place for about 7 days, especially partly because I was just so ill, I couldn't actually get out of bed. But then also just to protect them and protect the community, I didn't go outside. And logistically, it's been kind of difficult to do. I've not hugged my son in about a week, and it's been kind of painful emotionally, and sort of for him, for me, for my wife. But, it's obviously something we had to do. But I have to say that we've been very disciplined, partly out of fear that I don't want them to get sick. I've just been in this room, and I cracked the window open. But for the most part, I just have been here doing push-ups when I can, and, just kind of reading, a lot of reading.
So Ali, to put it in context for our members, because you've been talking about things like Sundays and Mondays and things like that. So you got symptoms roughly a week after your training course, is that correct?
Yes,
And
I would say it was about 5-6 days after is when I started feeling something, and then 1 week exactly from the days when I went home sick.
And we're about 12 days in now to your illness from the time of exposure, is that correct?
Yeah, we're a little over, almost from the time of exposure, we're about 2 weeks. But we're about, we're about 4 days from my last symptom, 4 or 5 days since my last symptoms.
Yeah.
Okay. So far, none of your partners have had to sit out?
So no, none of my vascular surgery partners, they actually all got tested right after I went home, and they were all negative. Partly it's because, I guess we just, before I got my symptoms, I wasn't around them as much, but, we were all in quite a few meetings together and we were in close contact. So it's remarkable, but every single one of them got tested. Every single one of them was negative. Aside from those 2 cardiac surgeons and me, we haven't actually had anyone else from the group. Obviously, a lot of people have gotten tested. Just the people that were in contact with us, are some of our staff, or nurses, or MAs. But so far, so good.
All right.
So one of the questions that's very important to all of our members is, how do you prioritize cases that present to you that may need to be done? And is that a physician decision or a hospital system decision in your situation? So
it's interesting. The hospital has, our chairman has essentially said, avoid doing elective cases, but it's in the purview of the specialties to decide what that is. I think a lot of what we do in vascular surgery cannot be considered elective. I mean, you could really argue that CLI, certain CLI patients can be elective, or symptomatic carotids can be elective if you really want them to be. But I think it really is case by case, and that's what we've been doing. One of the things I've had to do almost immediately was every patient that I had with CLI, with rest pain, I had to tell them, if you can hold off, if you don't have tissue loss and you can hold off for a month, let's revisit. If you can't hold off, if you're just in unbearable pain and it's getting worse, then I've had to give that off to one of my partners. I know that for carotids, we've also stopped. We had actually just this past Monday, we had 3 TCARs lined up. Obviously, I couldn't do them because I was still in isolation, but I actually canceled them, and I am following up in a couple of months. And they were all asymptomatic high-grade stenoses that we probably can push back for a couple of months with best medical therapy and try to prevent it. Obviously, if it was a symptomatic one, it would be a different story. We're trying to call these patients up and make sure they don't develop symptoms. And if they do, we have ways of sort of having them come and sort of streamlining that. But it's been, I think it's kind of, to answer your question, it really is sort of case by case. But we have minimized as much as we can. And I think our practice especially has been very conservative. And partly it was because, we had one of our own get tested positive and got sick from this. So I think it kind of hit home. And I know that, we had, ironically, that Sunday we had a group phone call, FaceTime call, trying to decide what we were going to do, elective versus non-elective. Were some of our partners going to cancel their veins or not, and things like that. And then I got, sick, and basically we had to assess and we started canceling things very quickly. And in some ways it almost took one of us getting sick to kind of really take this seriously and realize how much of a nightmare this can be if one of us is positive and we're seeing our patients, particularly our older patients.
Yeah, it'd be interesting to see, Ali, what that list looked like before you got sick and after you got sick.
Yeah, I mean, we have a very busy practice here, and I'll tell you that list dried up very quickly. It was sort of damage control mode.
I can't help but...
That raises the other interesting...
We're back? No. Well, welcome back. And I really think we got to express our appreciation to Dr. Irshad for being willing to do this. What you caught me doing was taking out a couple of props. And so, on the back of our hospital badge, and in this is a get out of jail free card to describe it, that our CEO sent last night, because we have this shelter in place order. And so all of the staff had to be given something that, if stopped by the police, that explains that we are healthcare workers and it's justifiable that we're out traveling around. So with that, before I kick this and hand this off to Kim, let me just remind everybody to text their questions. There are questions already coming in, Kim, but text the questions to DeBakey, DEBAKEY, text DeBakey to 37607. We're starting to look at these questions, and while Kim is moderating the online discussants, I'll sort through the questions and try and address these as we go along. So Kim, I'm going to hand this back to you.
All right. Thank you very much, Alan. Well, that was kind of a sobering tale that we've heard from Dr. Ershad. We appreciate him sharing that with us. Certainly not a distinction anybody wants to have, being the first SVS member to catch COVID-19. So at this point in time, we want to go ahead and kick off the panel. As Alan said, there'll be plenty of opportunity to text the screen, and we would encourage you to do that. At this point in time, I want to kick it off by talking.
So I'm off. Huh?
At this point in time, I want to kick it off by asking Dr. Ben Starnes.
Yeah, because he's going to kick some of these questions back to me.
Since Dr. Starnes is the epicenter, if you want, in the United States, and has, in fact, the longest experience, is probably further along on the curve than anybody else. So Ben, you want to talk to us a little bit?
Thank you, Kim. Thank you, Kim, and thank you, Alan, for hosting this. Good morning from Seattle. I'm going to go ahead and share my screen with everyone. And hopefully you can see this. I'm going to walk you through a little bit of a timeline here. These are the cases as of yesterday in Seattle. The first patient, the index patient, patient 0, if you will, arrived on January 19th from Wuhan into Seattle-Tacoma Airport. 2 days later, on January 21st, he was diagnosed with COVID-19, the first patient in the United States. In mid-February, the first community-acquired case was identified. And since then, we've had a rapid uptake of COVID-19 cases. On March 9th, the dean at the University of Washington School of Medicine canceled all work-related travel at the University of Washington. And this was when we had 172 cases with 22 deaths. Most of those deaths were at a skilled nursing facility called Life Center in Kirkland, Washington. Fast forward 3 days, and on March 12th, we decided to cancel all elective surgery at the University of Washington. Now, for us as vascular surgeons, we took that to mean, well, we'll continue to do aneurysms greater than 5.5 centimeters. We'll continue to do dialysis access, and we'll continue to do critical limb-threatening ischemia. That all changed 3 days later on Sunday, March 15th, when I made 2 phone calls, one to a man by the name of Germano Melisano, a vascular surgeon in Milan, and another by the name of Pier Antonio Grimaldi. And my discussions with them that lasted over an hour were shocking to me. They strongly encouraged me to stop all operations, to cease everything but true emergency operations in an attempt to conserve personal protective equipment, or PPE. We did so the following week, and just a week ago today, published a letter at SVS Connect, as well as on Vascular Specialist, a letter from Seattle. If any of you have not read it, I encourage you to go pull it up and read it. This letter generated over 50,000 shares. And if you look at the curve here, this was 1 week ago, we've now tripled our numbers. And I was hopeful that we were starting to taper off on our numbers as we track the growth rate below 1. These are cases as of today divided by new cases yesterday. And unfortunately, this morning, when I went online to look at the new numbers, we increased by 607 cases. Now, this may be because of increased testing, but you can see a spike in the growth rate. So we're still going up here in Seattle. And Alan, this morning, I looked at Houston, and Houston has 203 cases with 2 deaths. So Houston's at the very beginning of this curve. When we look at a logarithmic scale, though, we see that the curve is starting to flatten in Seattle, and it may not be as bad as we thought. Here we are on March 27th, 2020. We expect the peak to be on April 19th. We've got 22 days left to go. When we look at the available beds in Washington State, we see that we're not going to have it as bad as others with 0 bed shortage. We will be short 96 ICU beds, and we will need 236 ventilators. If you contrast that to New York, who are the New Yorkers are in a much worse condition. Their peak will be in just 9 days on April 6th. They will have a bed shortage of 35,000, 7,000 ICU beds short, and over 4,000 ventilators short. The lessons that we've learned and the reason for this discussion today, you know, we don't get to choose when a pandemic occurs, but we do get to choose how we respond. We've learned that there is no emergency surgical procedure in a pandemic, period. This is the Super Bowl for infectious disease specialists. For a surgeon, our Super Bowl when we're called to duty is in a mass casualty exercise. And any of you that have been in that situation, either in a civilian mass casualty or on the battlefield, you know that you have to do the greatest for the greatest number, the greatest good for the greatest number. And there are patients who are not going to survive. The ultimate role of a surgeon in a pandemic is to help grow hospital capacity by not operating and preserving personal protective equipment. At Harborview Medical Center, where we run 110% capacity at all times, we've been able to knock down our hospital admissions by 15%, and we have 30 available ICU beds at this time. Another important point is to preserve the 3 S's: staff, space, and stuff. Yesterday, I took this screenshot of Andrew Cuomo, the governor of New York, who announced that 40,000 healthcare workers had volunteered to come help with the backfill in New York. And I'll call your attention that there's not a single surgical specialty listed here. Surgeons should stop operating. This is our daily workflow. We do morning reports once daily, remotely. We limit our team to 1 attending and 1 resident per week. We've canceled all routine clinic and have initiated telehealth instead. We have seen a few patients for wound care removal and staple removal, only by a single provider, and we still conduct all of our conferences by way of Zoom. Our first attending vascular surgeon to run the service last week was Dr. Elena Quiroga, and the resident was Jake Hemingway. Next week, it's going to be Dr. Nam Tran as the attending and Dr. Becca as the fellow. This is my last slide, and I'll talk a little bit about what we term a vascular surgical emergency. Ruptured aneurysms with a Harborview score of 1 or 2. 2 of those factors listed, we will treat those patients. In fact, we treated one last week. Dr. Singh operated on a patient with a ruptured aneurysm. But if they have 3 or more points, we will not accept that patient because their mortality is greater than 80%. We will treat severe grade 4 blunt aortic injuries, any arterial hemorrhage. I did a gunshot wound to the carotid, so people are still shooting each other in Seattle. Complicated type B aortic dissections, we do not accept and transfer uncomplicated type B aortic dissections where they can be managed in an ICU just about anywhere with blood pressure control. Acute limb ischemia, symptomatic carotids, a septic foot requiring a guillotine amputation, and really the only venous emergency would be iliofemoral DVT with phlegmasia. So I would say, ladies and gentlemen, that this is a temporary challenge and that we all need to group together here and face this with optimism, confidence, and professionalism. That's all I have this morning, Dr. Hodgson.
Great, Ben. Thank you for those encouraging words and perhaps some sobering information about what we're going to be facing in the near future. Well, as you know, Tom Forbes, head of the SVS Doc Committee, has collated all of the various algorithms that members have submitted to Connect and through other channels about case prioritization, which is a hot topic right now. So I wonder if we could pivot right now to Tom and have Tom tell us what you've observed in those algorithms as they've come in over the last week or so. Tom?
Thanks, Kim. And I just want to spend a second and just thank Ben and his team for his leadership in this initiative. You've really taught us a lot over the last week or two, which is a rapidly changing environment. I think all SVS members are going to be subjected to some aspect of this, and it's just a question of where we are all on the curve. We've really reached out, and a lot of people have helped out fellow members by offering information with respect to their algorithms, with respect to what they're treating and what they're not treating. And I think we recognize that there's not just one cookbook approach to this, that it really depends on where you are in the curve at your hospital and within your group. So the SVS has taken the strategy, and this was led by Bill Schutze and the Clinical Practice Council, to collate these lists, to provide them for members on the website as well as on SVS Connect, so that you can apply them depending on what your work environment is and where you are on the curve. Now I'm just going to share my screen here for a second and tell you where we are, because this is truly an international situation, and where we are on the curve really depends on the spread of this virus, your population density, and then perhaps what benefit any prophylactic measures like social distancing and the like will play out. This is a web capture from this morning from the Johns Hopkins website, which shows the cases globally. You'll see the United States has over 80,000 cases currently. In Canada, we have 4,000 cases. However, there are densities, and you can see that the epicenter of the disease has moved out of the Far East to areas such as Europe, the United States, and the more densely populated areas in my country, which is very close to the Northeast United States. There's a lot of information on the website, and Ben showed some of it, but some of the data with respect to where we are in this curve. Currently, our hospitals are not being inundated with a large number of COVID-19 patients. We're diagnosing more and more cases by day, but these are generally mild cases and being managed in the community. So we're in the preparatory phase, and we have the advantage of taking the wisdom and evidence from Dr. Starnes' group and applying them prophylactically. So what are we doing right now? And this may apply to many of the hospitals and maybe many of the SVS members in the US that are in situations where you're preparing and you're not inundated with patients yet. So as Ben said, we want to preserve resources. There's a lot of pandemic planning that's centrally controlled by the government, both provincially and city-wise. Currently, we have closure of non-essential services. So the only thing that's open really are grocery stores and pharmacies. There's a rule that you can't have a gathering of more than 50 people. I know that that's different from some cities, but over 50 people. And there's active engagement around social distancing, both at home and the community. Our city of a couple million people, I've never driven in lighter traffic. The traffic is a pleasure driving to and from the hospital right now. And as people know, as they've seen this curve, the whole purpose for doing this is to prevent that peak from rising above what our healthcare system can deal with. With respect to clinical care, we've taken a lot of the information from a lot of centers that are earlier in the curve as far as dealing with this problem and prioritizing our procedures. So at this point in time, as a vascular surgeon, what we're doing is large aneurysms, symptomatic carotids, and very dense critical limb ischemia. We're predicting our peak in our hospital to occur in the next week or two. So we're really prioritizing those patients that can get out of hospital in the next week. And all other things being equal, we're also choosing a treatment algorithm that is less apt to cause complications and prolonged stay. I.e., all things being equal, we may prefer a less invasive endovascular approach over an open approach. With respect to clinic activity, which is in our system hospital-based, basically our clinics are seeing very few, if any, patients in person. The vast majority are being seen over the phone or via telehealth, and that's all as the last week or so. And the whole goal is, and Ben calls it the 3 S's, but it's protecting and preserving resources, both human resources and physical plant. From a human resource perspective, we're limiting the number of healthcare providers in the hospital. So there's one resident and one staff person on call each day, and the rest are working from home. And part of that is to protect us, but also to protect our patients. We're preserving personal protection equipment for when the deluge of these patients come. And this has resulted in us having a little bit more bandwidth. Currently, our hospital occupancy is just over 70%, which is unheard of in our healthcare system. Usually we're running at 100 to 110% at least. So at least there's a buffer as far as capacity. The hospital has ordered over 100 additional ICU beds, as well as things like masks and PPE. We are an academic health sciences center as well. We have an active research program, and we have a teaching program as well. And I just did our weekly teaching rounds just before this session, and we did it on Zoom. So a lot of these scenarios and a lot of these teaching sessions are now being virtually delivered. So these are some of the preparatory steps that we're taking to try to maintain our capacity for where we're expecting our deluge of patients in the next week or two. Thank you.
So Tom, thank you for that. If you'll share your screen back, it looks to me like Alan's got a whole bunch of text to screen questions back there. So maybe we'll jump to some questions.
So let me tell you what the questions are, and then I'll let you kick it off to whatever the panelist is you think is most appropriate. Following this, we're going to put in some online questions. We'd really like to get an idea of where our membership is and what are the burning issues of the day. So the first two questions that came up was basically, might this be an opportunity to push for enhanced reimbursement for open and endo-AV fistula access creations in the outpatient setting? I guess the rationale for this, that currently the hospitals have no capacity, backlogs are growing, and should we basically be moving a lot of this stuff to the outpatient setting? I believe there was a Medicare statement last night about how dialysis access needs to consider to be of priority. So Kim.
Yes. No, I agree. And actually, you just did a great job keying up our next speaker, who's Dan McDevitt. So I think we can come back to this question and fill in the gaps if there are any after Dan talks to us. But Dan is here with us from Peachtree Vascular Associates in Atlanta, and he has an OBL. And I had a discussion with him just yesterday about what role the OBL can take in offloading some of the hospitals. It's interesting that in a discussion yesterday with Tom Forbes, it's apparent that in Canada, when the provincial healthcare system declares no emergencies can be done, there are no OBLs to offload capacity. That ruling goes across all healthcare facilities in Canada. But in the States, we have OBLs, and we have a potential outlet. So I'm going to turn this over to Dan McDevitt now to share his thoughts with us about that. Dan?
Thank you, Kim. Thank you, Alan. Can you hear me okay?
Yes.
Yeah.
Okay, great. Yeah, by way of background, I am in true private practice in a suburb of Atlanta, Georgia. Actually, my office is not too far from the airport that literally all of you have changed planes in. I own and operate my own office-based lab, and I am not supported by any other outside financial entity. As you may be aware, community practice surgeons are a vital part of the vascular care team. We do a significant amount of the vascular surgery in the United States. We help our patients stay in their own communities by providing access to great care near their homes. In addition to that, we're also an important economic entity for our communities. We employ directly and indirectly a lot of people through our practices. We are often hospital leaders, and they're community leaders as well. Our presence is a significant benefit far beyond just the medical practices that we run. We're also small business owners, and we're charged with more than just practicing surgery. We're the financial stewards of an enterprise that provides the family incomes for our employees and many others. We also assume long-term obligations such as loans and leases, and are often personally liable for our debt service. Failure of our practices can have a far-reaching consequence, including job losses, personal income loss, financial insolvency, and even personal bankruptcy. In such circumstances, the community may not be able to replace a surgeon who has to leave because of these disruptions. Over the last few decades, care has become increasingly concentrated in fewer locations, as was mentioned earlier. This has happened for a variety of reasons, but the current crisis has illuminated a fundamental weakness with this plan. Hospitals are now the go-to places for the care of the COVID patients. The possibility of being overwhelmed with patients, the shortage of PPE, and in our area, blood shortage as well, has all but shut down the ORs and the cath labs for elective cases. However, as you all know, vascular cases are only relatively elective. There is the potential for harm by delaying the care for patients in deference to the COVID patients. Our patients deserve care as well. Right now, we're left with the prospect of either delaying care or taking our patients to the hospital where we know the coronavirus is present and that the potential for nosocomial transmission exists. It's not much of a choice. As a result, many of us are in a holding pattern with our patients right now. A surgeon who cannot operate is in a difficult position. Community vascular surgeons cannot be repurposed as, say, pulmonologists. This leaves little for us to do to continue earning a living while we are in the current situation. Having my own OBL has provided some flexibility in this extraordinary circumstance. We continue to address urgent issues with dialysis access and threatened limbs, as well as some other pathology as well. We can do this without utilizing hospital resources such as PPE, bed space, and staff. We can keep our patients away from known potential sites of exposure to COVID-19. In general, each case done in our office uses less PPE and other equipment than is used in the hospital for a similar case. So there actually are some benefits as well. Of great importance, we can continue to do cases which provides much needed revenue to our practice, which helps us keep our doors open and our employees working. We really can't be there for our patients if we go out of business. I don't really know any vascular surgeons who are not routinely busy under normal circumstances. Delaying care right now has the potential for creating conflict between backlog cases and newer cases in just a few weeks or a few months. Also, once the resources are available again at the hospital, we'll have to compete with our colleagues in other specialties for precious OR and cath lab time, knowing that they're all experiencing the same backlog. Taking care of cases today will help reduce the pressure on our time when we come out of this situation. My OBL has allowed me to keep practicing to a greater degree than I would have been able to had I been dependent on the hospital alone. And I'm happy to answer any questions about what we're doing for those on the live stream.
All right, great, Dan. Thanks. That was very helpful information. We appreciate you sharing with it. This it didn't answer all of the questions, and I didn't expect you to, because a lot of it was about government activity and advocacy to try and change the reimbursement paradigm around sites of service and procedures done. And, you know, it's extremely hard to predict how all this is going to play out in the shake of COVID. There's obviously going to be major changes in our healthcare system, but site of service is clearly something we're going to need to look at. I wonder, however, if Dr. Starnes would agree or disagree with you, because he seemed to imply that only absolute life and death emergencies should be done in any location. And then, Alan, you might want to also be looking through your text-to-screens and see if you have any other questions before we go on to our other panelists. But Ben, may you want to comment?
Will do.
Yeah, I'm happy to comment on that. So I think we all have to kind of take a pause here and look at what's better for society. Mm-hmm. These patients, in my mind, can get a tunneled mind and continue to get hemodialysis, but these are the most vulnerable patients. If they're exposed to the COVID-19 virus, they have a significant chance of dying from it. That's a life and death situation. I understand that they're on hemodialysis, but I believe that we're potentially not only using resources that could be used for others, but we're potentially, not in line with what we need to be in line with right now. So we're not doing urgent. We'll do ulcerated dialysis access if there's a concern for blowout, if there's an infection, something like that, but we're not doing new hemodialysis cases or fistula placement.
Ron Dahlman, I know you had some information you wanted to share with us about personal protective equipment, when you need to wear it, when you don't need to wear it, how much you need to wear, and various other circumstances. So could we switch this to Ron Dahlman and let him share his screen?
Can I interrupt while you're doing that, Kim, and take some of these questions, because there's a lot of them.
Okay, go for it.
Okay, so, and some of them Ron may address, we'll see. So one question, did the American College of Surgeons rely on the SVS to inform their guidelines for vascular surgery care? In other words, did ACS coordinate with UKIM?
Yes, actually Tom Forbes, as we said before, head of the doc committee, worked with Bill Schutz to assemble all of those guidelines. And yes, the ACS took the guidelines we had assembled and actually got them posted shortly before we did.
Okay, Dan, one for you is, what kind of cases are you not doing in your hospital or OBL?
What kind of cases are we not doing?
Yes.
Well, we're not doing venous angioplasties. We're not doing venous angioplasties or venous stenting. We had some trailing the other week that we had already scheduled that we did, but we're not doing any of those now. We're more or less deferring any elective cases that we can. The ones we're focusing on are primarily the dialysis access, as Dr. Starnes said. A lot of these folks can't wait for things, and if they lose their access, they're in a worse shape than they would be otherwise. And then also limb-threatening ischemia. Those are the primary things that we're doing, because I just, time lost is tissue loss, and even if you can put somebody off for some period of time, I guess we don't know if we've peaked or not, so we don't know how long that time is.
Yeah, I mean, I suspect we're all at different phases of this, and that's probably why the opinions differ so much. There's almost nothing that can be delayed for 2 or 3 weeks. When you start talking about 2 or 3 months, things start getting a little bit more shaky. And one argument is try and get all of those cases done as early as possible before we actually get into the kind of situation that Ben's in at the moment. We basically essentially shut down everything at the present time. And one of my partners, Eric Peden, does a lot of dialysis access. He's going to do a live stream on Monday, actually, because I'm telling you, the nephrology community is very opposed to shutting down dialysis access maintenance, maybe even dialysis access creation. So I think stay tuned on that. What are the current conversions from endo procedures in OBL to needing an open surgical procedure? In other words, you start off doing an endo procedure, but you end up having to use hospital resources, for example. How often does that happen, Dan?
In our hands, it really hasn't happened at all, during this process. In general, we try and do good patient selection and do good procedure selection because we don't want that complication.
Okay, I guess there's one for you, Tom, perhaps. Is any chance the SVS can release a statement specific to dialysis? And this is kind of this paradox that we've got. The nephrology societies are coming out and saying, hey, this is this patient's lifeline. You got to keep doing this. And yet, basically, a lot of us have really tried to minimize doing these procedures. Ben's shaking his head pretty vigorously there. So this is going to be interesting, the debate. Tom, you going to help us out?
Well, Alan, I'm not going to help you out with an answer other than to say I recognize that this is an extremely controversial area, and people have the best interests of the patients and resources in mind, I hope. But I think it's something, there are differences of opinion, as was mentioned, from our nephrology colleagues as well as from our vascular surgery colleagues. I think at the SVS level, we need to have some further discussion about that, but it remains one of the most controversial issues today.
Okay, Ben, one for you. Can you comment on which team members should be restricted from clinical care, age, gender, immunocompromised? One of our partners is pregnant, and Linda's at home, and we've got a fairly sizable team. What happens if you only got 2 or 3 people and one of them, is compromised or pregnant?
Yeah, so we have currently 7 trainees. We have one who's pregnant. We have one who's COVID-19 positive and is self-quarantined. And so we don't fortunately have any that are immunocompromised. And what we've done is we've limited their exposure, the residents' exposure, to a week at a time. So there's one attending and one resident that round every day with a backup attending and a backup resident. Because if one of the attendings or residents tests positive, they're going to have to self-quarantine for 2 weeks, and we're going to need a backup plan. So my colleague, Dr. Singh, has actually been put in charge of all of the surgical residents and creating a pool of backup residents and a whole plan for managing this process.
Okay, note from Gary Gwertzman from Mount Sinai in Brooklyn. They got 146 positive patients out of 220 beds, but two-thirds of their entire patient population is COVID. I don't think we need to comment on that. Our sympathies, and as I say, we're going to hear from Darren Schneider in about 30 minutes. I think one of the questions for the membership is going to be, okay, we want to delay as many cases as we can. There are clearly going to be consequences from that. And then we're going to be dealing with the malpractice lawyers who are going to second guess every decision that's made. I think, I wonder if that's where having a state of emergency or our governor saying we can't do elective cases. Question is that going to give us a shield from being sued down the line? I don't know that anybody knows the answer to that, so just let's keep going. Given the virulence of this disease, what do you recommend the vascular department do to avoid the worst case scenario? And have you been affected by this? I think you've kind of addressed that, Ben. I mean, you've probably got more insight than the rest of us at the moment. Any knowledge of the efficacy of reusing disposable N95 masks for personnel in the clinic? Anyone want to take that on?
Well, that may be a good lead into Ron Dahlman, who is going to give us some insight into personal protective equipment as well. I'm not sure if Ron has that answer, so I don't want to put him on the spot, but at least it's his topic.
So when we come back from Ron, we're going to pose a series of questions that we really like you to vote online. So again, if you text 37607 and then type in DeBakey, we're going to ask you a series of questions. Part of this is so we know what's going on, but it's also very helpful for us to know what your concerns are and how to shape these future town halls. So I'm going to hand it off to Ron at this point.
Okay, thank you, Kim. Thank you, Alan. Thanks everyone for joining us for this important town hall today, and we're really kind of encouraged that our membership is interested and leaning forward and kind of engaged with how to best help their patients and keep their partners and colleagues in their health system healthy and able to care for their patients. I noticed on the stream of comments coming up that Fabio Verzini from Italy mentioned that 44 Italian physicians passed away from COVID-19. And so being able to take care of ourselves and our team members is a really important part of the algorithm for how to really operate and maintain a capability in this environment. So I'm going to go ahead and share my screen. Let's see. Great. No. Let's see. There we go. All right, and let's go to. All right, and let's head back to the beginning. Okay, thanks everybody. This is the COVID-19 provider safety consideration discussion. So these are recommendations from our health system about what type of personal protective equipment is best suited for different environments. And you can see on this table, this is ambulatory and inpatient non-procedure patient encounters, classified as high risk, moderate risk, or low risk. And the definitions are in the second column there. Basically, whether or not they're an active COVID patient or patient under investigation, or whether at the bottom of the list there, they're asymptomatic patients. Currently, we're putting surgical masks on patients who have flu symptoms or known to be active COVID. And you can see the staff and provider recommendations. In our health system right now, a mask is optional, but gloves are recommended for asymptomatic patient encounters. At the other end of the scale, single-use N95 mask with goggles or a protective face shield, the point of the face shield being to prevent droplet contamination on the mask, as well as gown and gloves. And we have a 10-minute video on our health stream through our health system that you have to watch and sign off on in terms of the donning and doffing of the PPE. And you can see some special categories here at the bottom, and we'll get to some of those in just a minute. When we look at the interventional platform, then we're moving away from ambulatory and we're talking about the actual operating room. So it's clear based on the experience in China and Italy at this point that the highest risk patient procedures have to do with airway management. Interestingly, ophthalmologists, otolaryngologists, and anesthesiologists, of course, seem to be contracting the disease at the highest rate. And high-risk procedures include intubation or anything involving upper respiratory tract or GI tract. with risk for aerosolization, such as endoscopy, bronchoscopy, laryngoscopy. And interestingly, we're not using high flow masks or Venturi masks or anything like that in the ICU because they're thought to increase the risk of aerosolization. And so we're going almost directly to intubation for patients who are having trouble maintaining oxygenation or blowing off CO2. And so again, you can see by definition here, either active patients or asymptomatic patients, what the recommendations are for working in this interventional procedure environment. And it's our feeling, or the feeling of our epidemiologists and infectious disease people, that the N95 mask with face shield and goggles is equivalent to the spacesuits that the orthopedic surgeons use for their total joint procedures. Low risk procedures, this would probably be something that vascular surgeons are more involved in. By the way, in the high risk scenario where patients being intubated known to be COVID-19 positive, all the team is supposed to stay out of the room, all the patients intubated, and then come into the room after the airway's been secured and the other risk steps have been taken. For low risk steps, the ones that are not thought to generate aerosolization, you can see what's recommended for patients who are known to be COVID positive versus asymptomatic. And I would just point out that this entire live stream is being recorded. It'll be able to be seen later on YouTube, and we'll be able to feature it on the website of the SVS. Just for those you aren't familiar, this is N95 face shield. This is surgical mask and face shield. Again, the point of the face shields are to prevent contamination of the mask. So you continue using, particularly the N95 mask, as long as it doesn't get contaminated for the entire day if necessary. In terms of pregnancy considerations, and so this is kind of a little more ad hoc, you can see that the CDC definition of what pregnancy risk, and you can see the website at the bottom down here if you have specific questions about this. Currently, we've asked our team members to basically stay home, or our surgical staff who are pregnant to stay home and not be involved in patient care. I think the hospital, in terms of their staff, is handling this a little bit differently. You can see these two considerations here. We recommend that pregnant faculty, training, and staff limit, whenever possible, direct care of patients confirmed or suspected of COVID-19. That's not what we're doing with our colleagues on our team specifically, but that's the hospital's recommendation at the current time. There's also this issue about avoid in-person patient care contact at all after 37 weeks of gestation. All of us, I think, have a lot of questions about the situation. As Alan alluded to, the live stream is just loaded up with questions. Our Department of Medicine has Grand Rounds, which is live streamed every Wednesday morning at 8 a.m. Pacific time. This last week's discussion was on using bioinformatics to predict progression of the pandemic, depending on what the situation is now. That's archived on YouTube. You can also live stream yourself by logging in. Department of Medicine at Stanford, you'll see what the topics under consideration are for the next 2 weeks. For example, a question came up earlier today about the sensitivity of testing for COVID-19, and for bronchial alveolar lavage, it's like 95%, but for nasal swabs, it's only about 66%. So we should expect a significant number of false positive tests with nasal swabs, and so it's important to keep that in mind when we're considering ruling out COVID-19. And then finally, in terms of using AI to help us understand the progression of the pandemic and what's likely to happen in the next weeks to months to years, in both the United States and around the world, Stanford's having a virtual conference specifically looking at the application of AI to understanding the trajectory of the pandemic. So thank you very much for asking me to participate, and happy to answer any questions that I can about what I know to be issues related to personal protection. I'll go to stop share.
Well, thanks, Ron. I appreciate your insights. Do you want to take a stab on the reusability of N95 masks?
Yeah, actually, we had a discussion about that yesterday, and there's a couple of different proposals. One is a heat-based proposal, and another is more of a disinfectant. And our head of ID is apparently we're doing some work now to see if we can validate some of those recommendations. I think the one that's thought to be most effective right now is heat-based, and I'm not recommending anybody do this, but there is a potential for exposing it to heat or steam or some other form of heating for a period of time that may may allow for reutilization of N95 masks.
All right. I suspect Alan's ready with some questions or to pose some questions. Which is it, Alan?
First of all, we're going to pose some questions, and then we're going to switch back to try and answer some of the questions. So here's the question is, where is your practice on the COVID-19 pandemic curve? No presence in my region. You'll see that's A. B is a few cases, but minimal impact on my practice. C, preparing limits guided by priority protocols. Full restrictions, no elective procedures, surge in cases, that's D, and conditions improving after early restrictions, E. So while you're doing that, I would say Ron actually, there's been some talk about using ozone to re-sterilize N95 masks. Have you heard anything about it?
I heard that discussed as a possibility, Alan. I would caution everyone that most of this is investigational, as is the use of remdesivir or hydroxychloroquine, as was discussed earlier. And we're actually participating in a remdesivir trial, and so far, as was discussed, we discussed on a conference call earlier this morning, the patients who've gotten it, it's hard to tell a difference in terms of ones who have or haven't. So I think there's a lot of discussion and speculation about what's going to work, but let's try to stick with CDC recommendations for what we know to be effective at the current time.
Okay, doc. So I think you can see we're going to show you what these results actually look like, and about.
Alan, what's the N, Alan? How many people are responding?
I don't know. You ask hard questions, Kim. Do we have any idea how many people have responded? We don't know. You can't tell. And so you've got 67% basically in D, which is full restrictions, no elective procedures, and everybody else is in a limited protocol. So nobody in N, B, or E interesting left. So give us the next question. Are you experiencing a shortage of PPE equipment? A, yes, B, no. While that's coming in, it takes a little bit of time to tabulate if you've got any other questions to ask him. So let me just talk about airway teams, because one of the things that's been done in our institution is that anesthesia is split into 2 airway teams. All of the intubation is being done with a PAPR, and the entire OR staff is cleared out while that intubation is actually occurring. And so anything going on in the other institutions? Tom?
Yeah, no, I think that's an interesting concept, Alan, and I think we all recognize that airway management, both in the induction of general anesthesia and the withdrawal from it, is a high-risk procedure for anesthesiology colleagues. At this stage at our institution, there are not separate intubation teams, but each anesthesiology provider and house staff that are doing the induction are in full PPE. I think it's an important reminder that it's expertise is important, and in high-risk procedures, the person who has the most advanced training should be doing the intubation. So although as surgeons we can intubate patients, I think we probably should be deferring to our anesthesiologists.
Okay. Any plans to teach you or give you a refresher course on intubation? Oh, you laugh. That's exactly where we're at. It's about to start happening, actually. We're about to start doing refresher courses on ventilation management. Because last night our phase 3 plan, if we ever get that far, is basically to pull the intensivists out of the ICUs and to staff up with surgeons, and we're going to have to staff our own intensive care units. And the question is, what's the scope of practice and what additional incremental training do we actually need to do? So that really leads on to the next question. I think you pretty see most places are experiencing a shortage, but still 43% are okay. That question leads on to the next question. Go ahead, next one, please. Have you been asked to provide non-vascular COVID-related care?
So, Alan, while those results are coming in, let me piggyback on our last question for a minute and throw this over to Dr. Starnes. Ben, you said that anybody with a ruptured aneurysm and a score of 3 or greater, you don't put any resources into. Could you make the same suggestion for any COVID-19 patient that needs ECMO? I know Alan's been involved in ECMO in some of his patients. Yeah. I don't know what the survival rate is, but.
So our trauma critical care teams have an ECMO team, and they are completely in charge of that. I don't know of any COVID patient that we've put on ECMO yet, although we may have. As far as a ruptured aneurysm, let me just give you an idea of how much in the way of PPE a ruptured aneurysm consumes. So this patient that came in that my colleague, Dr. Singh, took care of last week, came in with 2 of the 4 points for a ruptured aneurysm. So Dr. Singh took him to the OR. He wasn't an EVAR candidate, so he underwent open repair. After that open repair, his left colon died and had to go back to the operating room to have a sigmoid colectomy. Went back for multiple washouts, eventually required an ostomy, and then eventually had an MI and had to get a coronary stent placed by the cardiologist.
Was the territory.
And after a week, you can tell the story. I mean, he now is on comfort care, palliative care. But if you look at the multiple providers that patient was in contact with throughout the hospital, not to mention the amount of PPE that patient consumed, guys, we can't do these types of operations. I mean, we're doing the emergencies the best we can, but we have got to get the picture here, and that is conserve PPE. Our role is to grow hospital capacity. That's our role, and by growing hospital capacity, I mean not operating. Don't do any elective cases, nothing, only emergencies.
All right.
All have
Back
a
to
sense.
Alan.
Yeah, let me ask Ben a question. We all have this kind of sense of denial. You know what it's like? Once you're in the middle of it, you get it. But trying to communicate what you're communicating right now to people who are on that early phase of the curve, we all hope we're not going to get where you are. But the reality is, you're right. We need to start conserving this now. And there's another patient reported from Michigan that came in with a type A dissection. Was successfully treated, 4 or 5 days later got respiratory problems, turned out to be COVID positive, and ended up succumbing. When they did contact tracing, there were 100 staff members who had gone through that patient and involved in their care and had to be sent home. I think that's really what you're talking about, Ben. It's not just PPE, it's the impact on the staff.
That's right.
Okay, so looks like, have you been asked to provide non-vascular COVID care? At the moment, no. That may change. So can we go back to the other questions that we're rolling in? We'll see if we can deal with some of those. Okay, so let's go to the bottom. With large community spread, okay, go ahead, give me the bottom. Here's an interesting question. I don't know the answer. Are there any vascular specific complications other than ECMO cannulas, for example? Anybody know any vascular manifestations?
DVT.
Pardon?
So these patients are hypercoagulable and they're developing DVTs, and they need to be treated with anticoagulation. But that causes an issue with all of the ultrasound techs in your lab that are going to be doing these DVT studies. So, that's really the only vascular complication of COVID infection that I'm aware of.
So that's very interesting, because one of the comments from the Chinese surgeons we'll look at later is that you need a separate room for doing vascular studies. And if they're COVID positive or highly suspicious, you don't bring them up to the lab. You're better off having the tech go down, albeit into that environment. Okay, 2 questions. How does EMTALA apply when we refuse transfers, as Dr. Stern suggested? Will this be recorded for later viewing? You want to comment, Ben?
What's the question?
It's about liability, basically.
Well, let me say that the SVS was asked a question about whether EMTALA applied here or not, and we are turfing that over to Bill Brown and some of our people that are more legal oriented to put some posts up on Connect addressing this, but we haven't gotten that done yet.
Can I make a comment on this?
Sure. Yes, sure. Go ahead, Ron.
Our health system attorney mentioned that cuts both ways. So to Ben's point, if we decide to do an elective case now, or something that could be considered elective, and one or more team members somehow gets infected by doing that case, 6 months from now, it may not, the health system and the surgeon may have some liability in terms of deciding to do that case when elective cases were thought to be, not approved by the health system. So there's actually 2 ways to look at that. What happens to us if we turn down EMTALA now versus we decide to go ahead and do a case like the dissection case that Alan refers to, that then multiple people get sick and God forbid somebody dies. If that was an elective case, there may be consequences for that down the road.
And maybe, Ron,
I
that
was
helps
just-
address this question: is how can we best address the requests we're receiving for assisting in what we would characterize as elective surgery, like ALIFs?
I mean, that's where we're just
Who
talking.
wants to take that?
Yeah.
Yeah, well, we had that very situation this morning where we had a provider that was asked to participate in the resection of a high-grade sarcoma, and that procedure is actually going on right now. There are still oncologic operations that are going on because there is a timeline, and there are some guidelines put out by the American College of Surgeons that look at certain solid organ malignancies or other malignancies that need to be operated on sooner rather than later. And I think that we have to just take those on a case-by-case basis. But a spine exposure for an elective back operation, absolutely not.
Agree with that.
Any dissenting voices? No. Okay, here's one for Peter Glavitsky. What does the panel think of doing CPR in patients with COVID-19? Yeah, I think I know your opinion, Ben. Anybody? So is that just a no across the board?
Well, it'd be interesting to know what the survival rate is for
Yeah.
patients who require CPR, and particularly if it's a COVID-19 related CPR, like can't oxygenate, can't ventilate, or they've developed an arrhythmia or from myocarditis. You know, I don't have a comprehensive understanding of those outcomes, but my sense from what I've understood is that the survival rate is extremely low. So, you know, it's just like with the stage 4 ruptured aneurysm patient that Ben's talking about. We kind of have to understand what's the likelihood of actually getting, you know, survival. If a patient can't be oxygenated and they arrest, I'm not sure there's much any of us can do about that. Even trying to get them put on ECMO, unless the ECMO team is standing by, and then, you know, in best case circumstances, mortality rate for ECMO is tremendous, 20, 25%, whatever. So,
Yeah,
you know,
that's true, but of the influenza cases, they're the ones who survived, actually, when the H1N1 a few years ago. Yeah, when you put them on for cardiac problems, it's dismal. But in general, in the past, nobody's got that kind of experience in COVID. It's not been that bad for influenza, standard influenza. Maybe we'll hold that for Don Schneider when he comes on, because that's a very relevant question in New York. Okay, what about surgeons over the age of 65? Should we be considered a high-risk group and restricted from being in contact with those patients? You want that, Kim?
Oh,
getting called out there,
thank
Kim.
you, Alan. I appreciate that all the time. Well, clearly the data we're hearing is difficult to interpret because we don't really know what the N is. So we don't really know if, in fact, the elderly are a more significantly at-risk population. Clearly, I would say that many of my colleagues in a similar age group are probably not really up on our intensive care management, certainly not ventilator management, so we can't provide any value there, but we may be able to play other roles in supporting roles in the hospital. I'd be interested in Ben's situation or others to comment. Have they excluded certain age groups or certain disease cohorts from working?
So we have two providers who currently don't take call. So they're not operating right now, who are actually three who are over the age of 65, and they're not operating right now. I would switch that around and say, how do you get a 65-plus-year-old vascular surgeon to stop operating? You know, let's say that they're the chief of a division or of a chair of a department, and they feel as if they have to operate to continue to for the betterment of society, and nobody is strong enough or a strong enough voice to keep them from operating. Has anybody had that situation?
No, I mean, speaking as being not quite 65, but you know, it's in the headlights. I mean, at the end of the day, when you're in a leadership position, you kind of feel like you got to be here, and you got to be part basically of this team, and you're heavily involved not just in taking care of the vascular surgery patients, but in the overall management of the hospital and the strategies and looking at how we're going to handle this going down the line. So the next question we kind of tiptoed into earlier: should we step up to help with ICU management as vascular surgeons if there are staff shortages in our hospital? So let me take that one on. You know, we were dealing last night with, as we've been doubling the number of COVID patients every 3 to 4 days. Looking at that, within 10 to 12 days, we will be almost at capacity of our current ICUs, and we're looking up to look at opening up PACUs and things like that. What we then want to do is pull all the intensivists, because we have the luxury of having great intensivists, and pulling them to take care of those patients. And what we're doing now is game planning how we will backfill them. And so the cardiac surgeons will be responsible for their patients, the vascular surgeons, the neurosurgeons, they're all going to be responsible for the ICU care of those patients. We hope we will not get there, but that's kind of how we're game planning this going forward. All right, go ahead. Somebody want to comment?
Sorry, Alan, I can comment on that as well. I mean, since we're in the planning phase, we are looking at protecting and expanding our human resources, and so we have developed lists at our hospital of both surgeons, and that's just not vascular surgeons, general surgeons, cardiac surgeons, heaven forbid orthopedic surgeons, who have put their name on a list that might be able to, I see Dr. Dahlman shaking his head. Put their name on a list that might be able to provide some expanded intensive care capabilities. That also extends to our research residents and fellows that may be redeployed, say, to the ED or to fever clinics or the like. So it's developing that repository of human resources.
Ron, did you want to comment?
No, I just I'm enjoying Tom's fantasy discussion there. That's good.
All right.
Alan, were we in the middle of a question? Have we seen the results from that last question?
I don't know. Did we see the results of the last question?
I thought we...
Well, let me deal with this one first. To the panel,
Right.
In regards to dialysis access patients requiring urgent or emergent care, how are the dialysis centers and renal doctors assuring the vascular surgeons and hospitals in their locales that the patients they refer have not been exposed at the dialysis center or do not have COVID? And how are they keeping these centers clean, and what are they doing with COVID and outpatients who need dialysis? I'm not sure we can answer that. So on Monday, we will put our Chief of Vascular, Eric Peden, what he does is dialysis access, and we're going to put our Chief of Nephrology on, because there are fundamentally different opinions from the nephrology community and the vascular surgery community. Maybe we'll be able to answer that with a little bit more objectivity. So can we go back to that last multi-choice question? So have you been asked to provide non-vascular COVID-related care? No, we did that when the answer was no. There was overwhelmingly no at that point in time. Number 4.
75-25, that's, as I recall.
Yeah, something like that. I don't know if we can pull the old ones back up.
That's all right. Don't worry about it.
Yeah. So why don't we go to question number 5? There you go. Yeah, you must be getting close to that 65, Kim. Your memory's beginning to fall apart. See, okay. Let's go to the next question that's up there. Have you or your partner had to go into quarantine? I presume by partner you mean professional partner.
Minority.
Look at that.
So I'll tell you my story. I didn't quite get put in quarantine, but I managed to go to Italy. Now that sounds at this point in time like the most ridiculous thing, but there were no cases. I actually went to watch a rugby game between Scotland and Italy. Met my brothers, and the day I arrived there were, in the newspaper, there were 3 cases. The day I left, which was 2 days later, there were 250 cases. And when I went to a rugby game with only 53,000 of my closest friends. Well, it's interesting that rugby in Italy is played in the north, in the Milan area. Of course, I had no idea that was the case. When I came back, the day after I got back, I operated, bumped into Rob Phillips, who's the chief medical officer, who was looking at a text he'd received, looked very concerned because he's been running our response to this. And I said, you look very upset. And he says, yeah, even Italy's now on this list. And of course, like an idiot, I said, well, I just got back from Italy yesterday. Well, that was me out. And so I basically was gone out of the hospital. And so if that counts as quarantine, you'd put me in the yes column. So it's a pretty dramatic number you're looking at there, Ken.
Mm-hmm. No doubt about it. Now, you didn't do an official quarantine, did you? You were
no, again, if it happened now, absolutely it would be. This was kind of when this was all really just evolving in Italy at that point in time. I mean, I think at this particular point in time probably should have been quarantined. No, I was just kept out of the hospital.
So you quarantined for symptoms? Were you tested before you could come back to work?
No. I mean, I never had any symptoms.
Okay.
Okay, so the answer is nearly almost a third of the workforce has been quarantined at some point in time. That's unbelievable it's that high. Next slide, my next question, if you got it. Okay, so we don't know the names here. This is all anonymous, by the way. Have you or your partner been diagnosed with COVID-19? All right. Well, that's reassuring. So we probably got Darren. Darren's holding in what we call the, well, actually, let's just deal with that question. If you own or operate an office-based lab, are you, okay, there's the answer. A, continuing to operate as usual, limiting cases to limb salvage and access, closed for the foreseeable future, closed and donated your supplies to the hospital.
That was an aspirational last choice.
All right. So limiting cases to limb salvage and access. It's an interesting idea that we keep those patients out of the hospital and send them to the OBLs. So Tyree, if you're ready, just let me know when Darren Schneider's on, and we'll get him in and hear a little bit about what's going on in New York. Meanwhile, why don't you just go to the next, if he's there, let's just go ahead and bring him up.
Hey, Darren.
Hey, Darren.
Hey, Darren.
Hi.
Welcome.
Thank you.
So Darren's the Chief of Vascular Surgery at Cornell, but you can tell us what you're going to do.
Soon to be.
So we've had a lot of changes here, and very similar to what Ben Starnes outlined, and actually we were making those changes as the letter from University of Washington came out, and that's for the most part what we've adopted. We no longer come into the office, everything's remote. We have a daily morning Zoom conference. Our outpatient clinic is closed completely and everything is telemedicine. And we have all of our non-clinical office staff actually now outfitted so they're working from home, answering phones, e-fax, access to the EMR and everything at home, in the interest of social distancing for the entire community and trying to kind of blunt the curve. For more than a week, we haven't done any elective cases, not even so-called urgent elective, and it's only true emergencies that are life or limb threatening that we're doing. And in fact, all the operating rooms and the PACUs here in our hospital are been converted into ICU beds, with the exception of 4 or 5 ORs that are going to be maintained. We've completely closed our vascular lab, no inpatient or outpatient vascular lab studies. We're using D-dimer tests and treating patients empirically for DVT with anticoagulation if there's a high suspicion. And our role is really dramatically shifting as vascular surgeons here in the hospital, because we have to preserve PPE, facilitate physical and social distancing in order to try to blunt the epidemic, which is out of control in New York. And so our role is only to be available to provide essential vascular services. And now we're being tapped for other roles. At one of our peripheral hospitals, one of our faculty members is now working in the ICU as an intensivist because they have a shortage and all their ICUs are full. And in our hospital here, we've organized a line service where we support the ICU teams basically by placing the central lines and doing other procedures that can be done all at the same time to preserve PPE. So that's kind of where we're at. I certainly hope that, the wave is definitely crested or is cresting in New York, and I hope it doesn't hit the other places the same way. But I think implementing these things, like Ben said, in the interest of the community, to provide physical and social distancing by shutting everything down and not having people coming into work, and to eliminate community spread, and then also to preserve PPE, like Ben said as well. We have a critical shortage. We're each hoping to be given an N95 mask, which we're supposed to reuse not just for a day, but probably for a week at a time. And we're told that there's some more supply coming, but these things are in short supply. So you don't want to end up in that situation where you continue to do cases that you could actually postpone or stop, because it utilizes resources that you will need to protect yourself and others if you get a dramatic increase in cases in your city.
Darren, are you actually seeing limits in your personal protective equipment and what you can use?
We've been able to get what we need, but we do actually have to run around to cobble the equipment together sometimes, because in some locations in the hospital, it's either locked up or it's run out. So like if we need face shields and things, we've kind of assembled our own little kit, and then you hang on to it. You disinfect your face shield by wiping it down with Clorox or alcohol wipes. And we're protecting our N95 masks by wearing regular surgical masks over them to keep them from getting soiled. So in terms of gowns and gloves and that kind of thing, there's not an issue with that. But it's really the masks and shields that have been in high demand.
Kim, let me ask Darren some of the questions that are coming up here. So for example, one of them is, how should we deal with our hospitals if they request our trainees participate in front-end care of patients during the surge?
Well, I mean, I think that everything is going to be relative to what's going on in your local area and the extent. I mean, here it's kind of all hands on deck. I mean, we've redeployed not only faculty, but the house staff throughout the institution are being redeployed in ways to help out. So, but that's because we're dealing with a major crisis here where we're already exceeding ICU bed capacity and having to create new hospitals and ICUs to accommodate patients. So everybody has to help out. I think that you can try to protect your residents and fellows as best you can, and certainly you don't want to have them exposed if it's unnecessary. So for instance, when we get called for consults now, we're even triaging consults, that if it's something that can be done remotely, giving advice by phone, having somebody send you a picture of a wound or something so that you can triage it and avoid contact. I mean, a number of patients that we've operated on in the not too distant past couple of weeks that we didn't know they were COVID positive, have actually tested COVID positive. So I think you don't want to be exposed to anybody that you don't need to be. And that's why we've shut down clinics and we're triaging consults. So we're doing that also to protect our house staff so that they don't have to go see every consult that they're called for.
Darren, are you affiliated with a wound care center, and how are they managing their wound patients?
Yeah, we are. In fact, we have a really large limb preservation program that we run through our division, where we run dedicated foot wound clinics basically 5 days a week. And we've shut that down. We're doing telemedicine. It's amazing what you can accomplish with telemedicine. I mean, you can have a patient, show you with the camera what their wound looks like and manage a lot of it remotely. And then if there's a true emergency, then those patients are the ones that are going to come into the hospital and be treated emergently. But those are high-risk patients. We don't want them coming into the wound center and exposing themselves. We don't want the staff to be gathered and exposed. And it is fairly remarkable what you can accomplish remotely when it actually becomes essential. So I think it will ultimately probably change some of the way that we practice in the future going forward as we become more, facile and adept at the telemedicine and remote approaches as well.
If reimbursement policies persist or change, yes.
Yeah, well, it's you can be reimbursed now. Right. I hope that that persists post this pandemic.
Any of the other panelists have any questions, Darren, or want to chime in with anything there?
Congratulations, Darren, for managing that situation so effectively, and hope you stay healthy. Take care of yourself too.
So Darren, stay with us for a minute and let me kind of push some of these other questions. Some of them I'm going to lump together. So some of them are philosophical statements like this one. With the large community spread of the virus, how is it okay to be doing cases in any OBL? I think we've kind of dealt with that. There's clearly a difference in opinion. Can you scroll up, Tyree? Because there's another question in relation to that. Hold on, right there. So let's say a private practice surgeon agrees that they should shut down their OBL clinic. What hardship resources exist for them and their staff? Kim?
Well, actually, this has been proposed as a topic that we ought to cover in another one of these town halls, and I think we're preparing to do that. That's come up, and our members want to know that as well. So you can look forward to that.
Okay, scroll down a little bit. Here's one that said just below, as I canceled the 4-centimeter iliac aneurysm, and the family made it clear that if it ruptures, they're going to sue me. So I really think Bill Brown and whatever group is working on it's going to be pretty important. And my question is, do these state of emergency declarations, either at state level or federal level, give us any kind of protection from that? And maybe Bill Brown's listening to this, and if he can text in the answer, that would be great. So one of the things is there's a lot of questions that are coming in now. We're prepared, if you are, to keep streaming after 2 o'clock, the 2-hour window, and just try and answer some of these questions so that we'll try and get to as many of these as we can. Are there any theories why healthcare workers are having more severe coronavirus symptoms than others?
I think the best I've heard about that is simply the repeated exposures and potentially other variants of the virus, but I'd be interested in what anybody else would have to say.
Yeah, I think one of the things about these panels is we really want to keep it limited to what we feel like we're experts in. I am not an expert in commenting on something like that, so let's just kind of move on. Does the panel feel there should be strict adherence to ACS guidelines, or is there flexibility for different surgeons in different locations?
Yeah, personally, I would think there is some flexibility still because we haven't peaked in some areas yet. And certainly the ACS guidelines are the way they published them from the SVS. There's some wiggle room in there. You know, we're all kind of charged with taking care of the person in front of us, and we have to make some tough decisions sometimes. So yeah, I think there's some flexibility there. And as regards to, legal liability, that's an interesting question, and I guess we'll find out. So
Alan, I would agree with Dan that there's some flexibility as we apply these guidelines, because we're at different stages of the curve. But I would just say to people that adopt the next stage of restriction of cases early rather than late, because by the time it gets to a full hospital like Darren and Ben has, it's too late to be flipping to being more of a selective protocol.
All right, scroll to the bottom, Tyree. There's a comment on it. None of us are wearing PPE devices. I'm always amazed at what people comment on. So why are you not wearing PPE devices?
So I can comment what we're doing here. We actually are now mandated to wear just plain surgical masks, anybody walking around the hospital, both patients and providers. But when we're in our offices and away from any people, I'm in my own academic office, you don't need to be wearing PPE. I'm hopefully not exposed or at any risk here. So it's to protect yourself and spread to others. And so when you're in that environment, and again, it's going to depend what the situation is locally for you, that's when you're using the PPE. And I think Ron presented, pretty well, when you escalate to the N95 face masks and the other types of things when you're dealing with patients who are suspected to be positive or are positive. But we've taken the policy now in the OR. We've been unable to get every single patient tested pre-op. That's an issue that we think they should be, so that we know whether to limit the personnel going into the operating room. But we're just handling every emergent operation that we do now as a potentially positive patient. So we really are limiting personnel to preserve PPE and to limit potential healthcare worker exposures.
So comment on the bottom is we've really scaled down as vascular surgeons, but cardiac surgery is continuing business as usual. Any advice on getting them on board as well? I can tell you that is not the case here. Cardiac surgery is essentially shut down. In fact, there's a thing came from our Texas Medical Board, and it said you do anything other than elective cases, it is illegal. You're subject to 180-degree imprisonment and a fine, and it encourages whistleblowers to go directly to Texas Medical Board and turn in anybody who happens to be violating that. That's in Texas. So, our cardiac surgeons are exactly the same situation that we are.
So that covers the whole state of Texas, or is that county by county?
Texas. Covers the whole state of Texas. Wow. Okay, doc. Guidelines from SVS should be put out saying if we should do AV fistulas, if the nephrologist requests it, it'll be difficult to tell them no. In other words, is there something the SVS can do? They're requesting a guideline, so there's something to rebut the request from the nephrologist to put the AV fistula in. Tom?
Yeah, I think we're hearing this loud and clear that our members need some assistance with this. There's obviously a discrepancy in viewpoints between our nephrology colleagues and us, and it is a controversial area. So we'll take that back as a message from the membership, and we'll get something out to you.
Okay, Doc. So let's deal with one more of these, and then Tyree will come to Dr. Zhong Chen and the comments from China. So before we do that, comment is we're working on 3D printed PPE here at Brown. Is anyone else looking at that? I know of multiple places that are looking at that. What's happening in Stanford, Ron?
Yeah, we're printing the face shields. We've got something ramped up where we can make hundreds of them a day. I don't know about the math specifically, but I'm sure multiple places are doing that as well.
Okay. So can we come to my PowerPoint? So what we tried to do was contact several of the Chinese vascular surgeons and to actually put them on the air. It just was going to be technically difficult to do that. So Kim and I put together some questions for them, and they very graciously responded to that. So if I can have my PowerPoint up, and we'll talk about from Dr. Chen. If not, we'll just continue to keep going with the questions that are up here. Okay, so here we go. Dr. Zhong Chen is the president of the Chinese Association of Vascular Surgeons, and you can see what his other affiliation agreements. You can see why we needed to get this translated. And Yuki, I think we're very grateful for you linking us up and for translating this very late last night. So I extracted from his letter some of the things that I thought were more pertinent into this discussion. Outpatient service was completely suspended. Only emergency service was maintained during the most tough times. All of these were from the perspective of trying to prevent the in-hospital epidemic. That's a slightly different angle from what we've been talking about here in terms of preserving the PPEs. They were really concerned about infecting the hospital staff. And meanwhile, patients didn't actually want to go to the hospital at that time, as most vascular diseases could be safely punted down the line. But interesting, what they were doing now is all patients have to be COVID-19 tested in advance of even being allowed into the hospital. And if they are high emergency cases, they're all treated as if they're COVID-19 positive. Again, if the panelists got any comments on this?
Well, I would point out that the risk is not just from the patients. So, for example, one of our sites had somebody from IT there to do a hands-on demonstration of how to do video visits and bill form through Epic. That person turned out to be sick, and then 5 staff people working that clinic site got sick from that person, and then that site had to shut down. Another circumstance, several of our psychiatrists are sick because an MA that was working in their clinic with them was ill, and they got sick from that person. So it's not just a forward-facing, patient-facing issue. It's everyone we're working with. We have to be kind of cognizant of what their risks are and use, good hand hygiene, social and physical distancing, like Darren was talking about. I mean, you have to have a 360-degree awareness about what's going around us, not just the issues with the patients.
So it's reducing the number of people who are trafficking through the hospital. And if you go back to that slide, you can see that the 2 things that were done was they call one ward for one patient. I presume that's just one room for one patient. And using remote care, including video, we actually have installed virtual ICU. That was pretty controversial. There was a lot of pushback from the medical staff against the administration. But I tell you, it looks like a brilliant move at this particular point in time. One of the controversial things, and heard that one of our sister institutions here in town instituted this last night, was all patient visit is suspended. In the Memorial Hermann system here, they have a couple of exceptions. Pediatric patients were one example of this. But what have you done, in terms of patient visitation?
So, Alan, at our hospitals, we've instituted the similar policies in that there's a no visitor policy with some specific exceptions, that being patients who are in the end stages of palliation, as well as pediatric cases, and those who are not able to have the mental capacity to make decision making. But that's posted outside the main doors of the hospitals throughout Toronto, and there's currently a no visitor policy.
Darren?
Yeah, absolutely no visitors. It became quite controversial, I think, last week when they said in, say, labor and delivery for women giving birth here in the hospital that they couldn't have even one visitor, parent or significant other with them. And that was quite controversial at the time, but now it's well accepted. So there's absolutely zero visitors. They've closed all the entrances to the hospital except for one. And they limit the traffic into the hospital. So, and I think that you know we're learning from the Italian experience that the hospitals themselves have become a major focus for spread of the disease in communities because of the concentration of people in those centers, people coming in, going back to home. And the high prevalence of the COVID virus, you know, that it's present throughout the hospital. So we've really tried to shut that down.
Anyone have any different policies?
Well, in Springfield, we're still allowing the spouse of the labor and delivery patient to visit, but no other family or anything. Okay. So it's not quite as restrictive, but we don't have anywhere near the penetration that they have in New York.
So to continue the lessons learned from China, for anesthesia, local anesthesia is preferred. They try not to intubate these patients. I guess that makes some sense. What about imaging? It said it's better to have a separate room. We mentioned this earlier. They try to have a completely separate room for patients who are COVID positive. And if possible, they actually go to the bedside. Again, Darren and Ben, you're kind of in the middle of this. What have you been doing with when you get the requests for DVTs, as you've heard there's an increased incidence of? Ben?
So I didn't hear you quite well enough there, Alan, but as far as our hybrid operating room, we're trying to reserve that for unless it's absolutely needed. We'll try and use other operating rooms for any of these procedures. Again, last week we had an open repair of a ruptured AAA and a gunshot wound to a carotid, so those were easy to do in a different room and reserve the hybrid operating room.
So let me pick up on that, Ben, actually, because I got asked that question last week. It's a long time since I used the portable C-arm, but I was specifically asked if we could use portable C-arms in a non-hybrid room because they're so much more complex to clean. Is that what you've been doing?
Yeah, well, we haven't been operating. So we've canceled probably 24 complex aortic cases in the last month. And we're following those cases, by the way. We're following not only the aneurysm patients that we've canceled, but also the critical limb threatening ischemia patients. And we're gonna find out who loses a life and who loses a leg. But you know, these are desperate times, and desperate times require desperate measures.
So let me turn it over to Darren then. If you get a request for an ultrasound for a DVT in a patient who's COVID positive in their ICU, what do you do?
Yeah, we've actually shut down our vascular lab. Radiology still may be doing some studies, but I think that we're trying to treat patients empirically. If we think that they're likely to have a DVT, we're using D-dimer tests in addition to clinical decision making and really trying to avoid that. I mean, the issues, like getting CT scans with PE protocols in patients who are hypoxic and things like that we used to do left and right all the time, we really have to stop doing that. I mean, you've got a patient, these intubated patients with COVID already have one organ system failed. We don't need to be giving them contrast and carting them around the hospital. We don't have to be unhooking them from the ventilator circuit, which can be an issue if they're actually being difficult to ventilate due to ARDS. And so you really have to change the way you're practicing in the hospital. And fortunately, you know, we've developed protocols hospital-wide just because we're becoming so familiar with dealing with this. But you know, practice as we know it really changes if your hospital is going to be hit very hard.
So we triage all of those cases on an individual basis. It has to go through the director of our vascular lab, and there has to be, if need be, a consultation with the intensivist about, is this going to change practice, and can we do without it? If we can avoid it, we avoid it, but we don't say no. Somebody else was going to comment?
Yeah, so Alan, back to the Chinese suggestion of limiting your vascular labs to one room when you couldn't do them bedside. What are you doing to clean that room after each case?
You're asking me?
Sure.
I don't know. I'm not in the room cleaning business, but it does bring up the point of, you have these environmental services who are responsible for cleaning imaging rooms and hybrid rooms and operating rooms, and they are really put out to task at the moment. So that's one of the reasons for considering that. We're going to try and avoid using our hybrid room if at all possible and switch over to a regular room. So the last point, so go ahead.
Make a comment about that. So we had an emergency case last night at 3 o'clock, and there's some protocol in place now where the room they have to leave it stand for 90 minutes before it can be cleaned, because the time has something to do with it as well. So the room turnover for the positive or the PUI patients has just slowed down dramatically, and it's really limiting our efficiency in the operating room. And I think there's, I don't know that's evidence-based, that maybe it is. I'm not sure what the underlying evidence for that is. That can be a real problem from an efficiency standpoint.
Yeah, I think so. The last comment is one that's disturbing. Is highly careful that there are many asymptomatic patients or mildly symptomatic patients who also are positive for COVID-19. I don't think any of us have really got a handle on this. And they're a little bit on the backside, but they're concerned about reactivation of the virus. And they really have to be planning to be very cautious and ready for this long-lasting battle that you think about COVID-19 that's not going to be over in the short term. So, Dr. Zhongcheng, thank you very much indeed for taking the time to respond to some of our questions.
Yes.
So while we're closing this out, you want to pull up the other questions that we can deal with, the ones that are coming in by text message?
So, Alan, do you want to give people instructions about how to do our rank order listing for a future town halls, because I know that's a little bit more complicated on this system, and we are getting towards.
Yeah, let them do it, because they're going to have to pull that up. So let them go ahead and pull up these questions first of all while I get this. Well, actually, if you're streaming me, let me just do it right now, because that's what this is. So pull that up, Tyree, please, and send that out. So the bottom line is, it's a little more complicated to respond on poll everywhere than to look at our rank list than it is actually to send in these text messages. However, we would really like, if at all possible, the number of people actually go onto the website. And this website is, what I want to do is, can you pull up the website? Are we ready for that? I want to pull up my computer. While we're doing that, let me kind of handle some of these questions that have come up behind me. Okay, so what steps are being taken at your institutions to keep trainee education going during this time?
I can answer that.
Go ahead.
We do all of our conferences. So we do our Tuesday morning conference. This morning at 7 o'clock, I had a faculty meeting and I had 28 people on the line. And we did a roundtable. So we actually went around and all 28 people had something to contribute during our faculty meeting. So we've become very quickly adept at using this virtual technology to communicate. We do our pre-op conference, we do morning report every morning, our Tuesday conferences, and our faculty meetings. So we're still in touch. And actually, some people here have actually we haven't had one yet, but in the Department of Surgery, other divisions have had virtual happy hours on Friday afternoons where everybody for an hour has gotten on Zoom and cracked a beer and told stories. And there is something valuable about that in terms of wellness. I'll be excited to hear the town hall that's coming up next week with Dawn Coleman and others talking about wellness and how we're going to address those issues getting through the next several weeks.
Took the words right out of my mouth, and I'll plug that again at the very end here as well, but that'll be next Friday. We'll be doing another one of these town halls where we'll be addressing issues related to training, education, and wellness.
Okay, so if we can show my computer screen, what we would like you to do is go to Poll Everywhere, and I'm going to let this is a little screenshot that we did in preparation for this, and it shows you how to do it. So what we want you to do is log into that, punch in DeBakey, type in DeBakey, and then it will bring up a series of topics that we put together. And you can change the rank order a little bit like doing that. And if you can do that between now and the end of the presentation, it will really help us to identify what the hot topics are going forward. So why don't we go out of that and go back to the questions. We still have a number of poll questions that we'd like to get you, but let's deal with some of the questions, the text message questions first of all. Okay, so here we are. Well, I guess this is one for you, Kim. Don't know if you want to take it. It's what is the current status of the VAM in June?
The current status of the VAM in June is under evaluation, and we really appreciate everybody's patience while we do all the due diligence to make sure that we protect the SVS as much as possible in whatever we do.
Okay, doke. And so, how should recommendations for emergent cases be interpreted across the country? How about in areas more rural where COVID surge has not happened? So that's a great question. Should there be a difference between what's going on in the rural communities versus the urban communities?
Well, clearly I think there should be, and I put that in a recent Connect post about that as well, that these guidelines are just guidelines, and you have to take them into perspective of where you are in your own situation, in your own institution, your own region, with regards to COVID and the needs for limited supplies.
Okay.
But I'm interested in anything else anybody else had to say.
Yeah, I mean, I've painted a pretty grim picture about New York, which is grim, but I think that all things are relative and local. Certainly, if your city is a place where there can be a crisis, you have to stop everything, I think. But if you're not in a place like that and you're in a rural area, then there may be some role for doing the so-called urgent elective cases. But I think that's got to be location dependent, and it's all relative.
Okay. Donate to SVS PAC. We need to pressure Congress for legislative protections for these non-emergent case deferments. Not exactly a question, but I certainly sympathize with the concept here. Any truth to statements saying ibuprofen is contraindicated? Anybody feel like they're an expert in commenting on this? Okay, let's pass on it. Without SVS dialysis access guidelines, we're at the mercy, but I think we've already done that. Why don't you delete those top three? Is there a role for the SVS, scroll on down please. Is there a role for the SVS to play in recruitment, allocation, and distribution of supplies or surgeons? For example, if a service line goes down due to exposure infection to hard-hit areas in greater need, can we reallocate resources and both personnel and equipment? Kim?
Well, certainly we don't really control equipment. We could potentially help coordinate transfers like that of equipment and supplies, but I think probably the more likely immediate consideration would be, could we serve as a resource for those who want to go serve in areas that are affected? And in fact, that was one of the questions, Alan, that you haven't posed to the group is, or actually that's coming up in the rank order, I'm sorry, as to whether that's something that they'd like more information about, is how they could help out in underserved areas that are affected.
Okay, let's go back to the bottom of these questions and take them in order. All right. Anyone started pre-op urgent case CT chest to screen? Again, one of the early things is the chest CT is abnormal. Let's pose it a different way. How early should we be getting chest scans? And maybe Darren, can you comment on the role of chest CTs in these patients when they come in?
I don't think that they're regularly being done. Again, it's a question of preserving resources, and there's no need to be transporting patients all over the hospital and doing scans. It may not be indicated. I mean, you change the way that you practice when you're dealing with a crisis, and you manage those patients as best you can, and you stop ordering shotgun approaches to testing everybody. I mean, we're testing patients for the PCR test for COVID if they're suspected to be COVID positive, but we're not getting diagnostic CT scans for that purpose. It really doesn't change your guide management all that much.
Okay, Ben, question for you because of your military background. Do you see similarities between this and the military's expertise in responding?
Yeah, absolutely. I kind of made those comments a little bit earlier. This is the Super Bowl for an infectious disease specialist or a pulmonary critical care specialist. When we have a mass casualty situation, we're going to be forced to make decisions on life and death issues. We're going to have to decide who we can apply the resources to do the greatest good for the largest number of patients. And many of us who have been in those situations before, overseas in Iraq and Afghanistan, when the ability to take care of patients is overwhelmed, you'll quickly learn that you want to conserve the fighting strength and conserve your resources as much as possible. Like I said earlier, the 3 S's: space, stuff, and staff. You know, conserve your personnel, conserve your space, and conserve your stuff. So, yeah, I think that the USS Comfort going to New York is going to be helpful to the citizens of New York. I think having the capacity for an increased number of hospital beds and an increased number of ventilators is going to be helpful. We're in a desperate situation, and Darren's closer to it than I am, because we have 22 days until we hit our estimated peak, whereas Darren's going to hit it in 6 days. And they're estimating that at that peak in New York, there are going to be 5,000 deaths every day. That's at the peak of the crisis in New York City. Imagine that, guys. Tomorrow is going to be much different than today. Today is much different than yesterday. So we've all got to get online here, and we've all got to take this incredibly seriously.
So here's a very poignant one. Anybody staying away from the family after work?
Yeah, so I've kind of set up my own little home physical distancing self-quarantine area. So I come in through the garage, I remove all my clothes that I had in the hospital. I go straight up to the top floor of our house, which is reserved for me only. There's a bathroom, I shower, I change into clean clothes. And then if I come downstairs, I stay away from my family. So I'm staying up on the 3rd floor just because there's so much virus in the hospitals in New York. We're putting central lines in patients. That's what our vascular role is right now in COVID positive patients. And I don't want to place my family at risk. So you can kind of, everything's going to be different depending on where you live, but there are ways that you can kind of set up a little protocol so that you can try to protect the people around you and the people you love.
Let me jump to the top. JVS is ready to fast track any publications the panel or anyone has that is valuable for us or our patients. That's really good. JACC Intervention actually have a special request basically for COVID related manuscripts that came out this week and had a very fast guideline and turnover. For urgent cases, is anyone able to test asymptomatic or pre-op patients or any move towards mandatory pre-op CT scan? Well, let's just deal with, do we have enough access to testing that we could even think about testing patients preoperatively at the moment?
So Alan, if I can speak to that for a second, because it brings up the issue of the CT that Darren spoke to previously. But at our center right now, every patient going to the operating room is tested, so that, and because that then dictates the level of PPE that is used intraoperatively. So patients are either known as known positive cases, unknown cases, or status unknown. So with our emergency cases in vascular surgery, a lot of the patients have had CTs because they're a ruptured aneurysm or a CTA. So because there's not time to get a swab done, we are adding CT scans of the chest to then dictate the use of PPE intraoperatively.
Any other comments? All right, for people in leadership positions, how are you helping to protect the salary of hourly workers under your charge while encouraging stay-at-home policies? That's a great question, and a question that's going to become more and more and more relevant as this goes on.
Probably the first person to field that might be Daniel McDevitt, because he employs people in an OBL. Dan?
Yeah, that's a great question, and I really think it's nobody likes to discuss money when we have crises like these around, but these are kind of real world things. I called around to some of my colleagues yesterday, and people are already furloughing staff because the business has dropped off so dramatically without elective cases that they can't afford to keep them in place. So, private practice surgeons are talking about not having any income for the foreseeable future, furloughing staff. There's always the potential for defaulting on payments to vendors, leases, loans, et cetera, like that. So it has a big impact for us. And again, I don't need to minimize anything that Dr. Starnes has said to us, because it's obviously a blossoming crisis, but I think this is going to be some of the collateral damage that goes on with this as well, is that we're going to take talented people and put them out of work.
Can I make a comment about that, Alan? I think that's an important from a more of a health system perspective. One of the issues for us is, we got to be careful not to cancel all of our clinics. And we're not in Darren's situation yet, so we can't really cancel all our vascular labs, because if we do that, the hospital is going to start furloughing our employees, as Dan kind of pointed out. The other thing is, for our surgeons, we have a highly leveraged productivity compensation plan. A significant amount of their comp is withheld quarterly unless they meet certain productivity targets. With our department chair, we've got an agreement to freeze that for this quarter. How we're going to deal with that going forward remains to be seen. But I mean, that is a huge problem. Try to figure out how to keep people income coming in and keep them part of the team while still trying to recognize the financial realities of what's happening with our health system. I think Ben pointed this out before. Our ER visits are down by a third. Right now, our hospital is about 70% full, which, like Tom's situation, is just unprecedented for us. We're losing tons of money as a system right now. So how do you keep your own group together in a situation where the entire financial situation is deteriorating rapidly? That's a real challenge.
Yeah. So I can tell you.
If I might comment,
go ahead.
If I might comment on that, I think that Dan's point was that we're going to have a huge backlog of cases, not only for vascular surgery, but for orthopedic surgery, for general surgery, neurosurgery. And so hospitals are going to respond to that backlog by opening up their operating rooms 24/7. And we're just going to have to catch up on those cases. And that's going to be a big influx of revenue, I think, into our healthcare systems. But we just have to wait the time.
Yeah, but Ben, the only thing I can say is, the analogy I use is that if the blood transfusion shows up after the patient's dead, it's really, it's not helpful. And I don't mean to be, melodramatic. I don't mean to be melodramatic about it, but that's what we're looking at. Is there's some financial realities to, at least practices like we run, that they can't go on. We don't have reserves for long periods of time.
Hey, Tyree, can we try and pull up that last question where we're trying to rank what the questions were that are going out? And let's shut down taking the text messages, and we'll deal with the ones that are already up there. And so now if you go to the last one, keep going. The one where they have to rank it.
Hey, did somebody really donate to their hospital?
Yeah, I think we're on this one. Yeah, number 9. Go to number 9. Keep going. All right, any comments while we're doing this? Yeah, we've done that. Go forward.
Well, obviously we're going to be very interested in whether this is meeting our members' needs, and we would encourage people to go to Connect and give us comments, suggestions, feedback, ideas. If you haven't been able to rank order these here now, you can give us ideas, or if what you want to see presented wasn't shown on this rank list, you can certainly send that in. Connect is a great mechanism, a great vehicle and platform to stay in touch with the leadership.
So we can pull that up, Kim, so that you can see it. And so this again, well, that's interesting. So we actually already have some results coming in.
Right.
So that surprises me a little bit. Legal considerations around COVID-19. Guess Bill Brown's going to be a busy guy.
We've already sent requests out to members for help on that one.
Okay, Doc. And so we'll keep this open for a little bit. You can continue to vote on it, and we'll share this. And so if you go back to the questions that were coming in on the text messages, this will be posted in the SVS website. It will also be posted by us on DeBakey CV Education website. We'll post it up. It automatically goes up after this. We'll edit it a little bit and repost it again tomorrow, but it will be available for anybody who wants to see it. Okay, let's deal with these last few questions and then kind of call it a day. What about our vascular techs? I think we've already dealt with that, actually. Ben, if you wanted to redeploy people, where would they be most useful, or are we just getting in the way?
I think we're just getting in the way right now. Our job is to grow hospital capacity. And like you said, I mean, if you have an ICU background, a lot of our trauma surgeons or trauma critical care doctors, they're going to be very useful. I've volunteered to push gurneys around the hospital. We're all going to be in this eventually. So,
All right, thank you. D-dimer is almost always high in COVID positive patients. I guess the direction of that is, does it help us or not help us in diagnosing DVT? Anyone have a, go ahead.
Probably unknown, but again, like Ben said, it's kind of the military crisis approach to caring for patients. I mean, when we weigh the risks and benefits of running ultrasound machines and personnel around the hospital, it's just not worth it. If there's a suspicion, then you treat the patient with anticoagulation. And we know that the COVID positive patients do have a higher risk of DVT or thrombophilic. So
this is a great question, actually. How do you suggest measuring where you are and what number hospitalized or ventilated? Ben, I think it was you that showed these really, really good curves that let you see where we were in the epidemic. Where did you get those from?
I will make that website. I'll send that website to you guys, and so it can be published widely. It goes state by state, so you can click on Hawaii and see where they are in the curve and what the expected death rate is, what the expected need for ventilators is, how many hospital beds are available in each state, how many hospital beds are going to be occupied, what the bed shortage is going to be, what the ICU bed shortage is going to be, and what the ventilator shortage is going to be for every state in America. It's a very powerful website.
So instead of sending it to us, Ben, could you put it up on Connect?
Absolutely.
That'd be great.
Yep.
Okay, another philosophical comment. If you want an SVS PAC to advocate, you're going to have to make some donations to it. Dr. Forbes, let's make this the last question, then I'll kick it back to Kim. Can you expand on the specifics of PPE used during COVID positive operations?
Sure. So what will happen if there's a known COVID case and you're doing a vascular procedure, the patient will be transported to the operating room with a limited number of personnel, only those necessary to transport the patient with full PPE. The most dangerous part of the operation is actually intubation and extubation. So during the intubation, the anesthesiologist is wearing the visor and the N95s, and the rest of the surgical team actually should be outside the operating room. You enter the operating room to do the procedure, and then you exit the operating room again at the time of extubation. And Ron talked about sort of the workflow. At our center right now, we're instructed that once the patient is extubated and is in the operating room, everybody needs to stand down for about half an hour until the patient is then transferred to the post-anesthetic care unit or the ICU or wherever they're going. And that's because of the dwell time, I guess, of aerosol particles.
So Kim, can I hand it back for you to close this up?
Sure, that'd be great. Thank you, Alan. Let me share my screen here. So I certainly think that this has been a beneficial, valuable experience, an opportunity for members to hear from others about what's going on. I do want to take this opportunity to remind everybody of our second town hall on COVID-19. This will be next Friday from 12 to 2 Central Time, and you'll be getting an e-blast about that in a minute or later on. This is going to be on the impact of COVID-19 on education, training, and wellness, and you can see the panelists there as well. I do want to thank all of our panelists for today, our inaugural COVID-19 Town Hall. I certainly hope that the members and viewers have appreciated it. We would like your feedback about it. We certainly want to modify this as needed going forward so that we meet your needs. And lastly, I want to thank the production team at Houston Methodist Hospital and Dr. Lumsden for all of their work in helping make this happen, including the back of Pat's head that we see because he's working from home, I guess. So in conclusion then, thanks to all who have participated and put hard work into this. We have many more of these coming up. We want to hear from you as to what you want panelists to talk about. And I'll turn it back to Alan, but in closure then, we want you to stay safe, stay strong, and stay tuned because there's more to come.
Yeah, thanks, Kim. It's a privilege for us to participate. The vascular surgery community is small, close, and we want to support one another. And I think Kim used this line, a line I kind of stole from Tom McGilvery, who's the chief of cardiac surgery here, and said, let's not learn alone. And so this is all about trying to share knowledge. And I thank Darren for coming in at the last minute. Ben, they're in the eye of the storm at the moment, and hopefully we'll all learn a little bit for you. So with that, we'll sign off. This will be posted almost immediately. Thank you.
Thanks, everybody.
Thanks,
Thank you.
everybody.
Thank you.